Hi, so my name is Alex Goltre. So I'm going to be talking about the management of acute respiratory distress syndrome, primarily in adults, and how we manage it. And we're primarily going to be comparing pretty much high frequency oscillatory ventilation and APRV. Okay, and we're going to get a little bit into those two modalities. But first, let's just kind of talk about what ARDS is. So ARDS is essentially just a sudden onset of bilateral infiltrations of the pulmonary system and hypoxemia initiated by, variety of different triggers. Um, it was first diagnosed back in 1812, um, essentially known as idiopathic pulmonary edema. But then after the World Wars and all the traumatic injuries that they saw, um, they realized that the traumatic injuries could actually result in a certain degree of edematous lung injury, and that's where they actually termed it shock lung. So right here, you can see that this is the Berlin definition of Ards, um, and essentially just kind of tells you what I just mentioned before. It's a diffuse lung injury that arises in patients with certain risk factors that all fall under the criteria. So onset, diagnosis, worsening, respiratory symptoms within the first week of injury, bilateral infiltrations and opacity shown in X-ray, as you can see in this X-ray right here. Um, any kind of and it could be like atelectasis, nodules, effusions, and then respiratory failure. Diagnosis is not due to either fluid overload or any cardiac failures or abnormalities. And hypoxemia is measured via PF ratio. And there's different types of severity of hypoxemia, right? We have a mild, so that's when your PF ratio would be between 200 to 300 millimeters of mercury. Then you have moderate, which is 100 to 200 millimeters of mercury. And then a severe hypoxemia will consist of a PF ratio um, under 100, essentially. And it's interesting, about 5% of patients who are on mechanical ventilation meet the meet the criteria for being diagnosed with ARDS. Some literature out there actually states that 5%, that 25% of those mechanically ventilated patients have mild diagnosis of ARDS, and the remaining 75% actually have a severe diagnosis of ARDS. And it's interesting, actually, within the last 10 years, the morbidity and incidence of ARDS actually has been continuously reducing. This could be due to a variety of different things. It could be the fact that we've advanced so much in our critical care medicine and our units. We've dropped, there's been a lot more awareness of nosocomial infections and how to prevent them. There's been enhanced education, better resuscitation techniques, better administration of antimicrobials, different improved strategies on restrictive transfusions, and lots of different bundles and improvements when it comes to ventilatory support and just understanding how to apply lung protective ventilatory strategies, which we'll actually get into in a little bit. And it was, as far as epidemiology, there was this international study that was conducted back in the winter of 2014. It was a cross-sectional analysis that covered over 50 countries. It looked at a little over 29,000 samples. It stated that 10% of the IC patients in the study had ARDS based on the Berlin definition that I mentioned earlier, and there was a 23% incidence in mechanically ventilated patients. And for the mortality of the samples in the international study, it was kind of unclear whether or not the patients had died from just strictly ARDS, or if there was other comorbidities that had to do with it. Although it was clear that these patients who were immunocompromised, like that subgroup, there was a clearly was significantly higher mortality rate with that subgroup. In that study as well, they found that 35% of those patients had mild ARDS, 40% had moderate, and 46% were diagnosed with severe ARDS. But unfortunately, our recognition and diagnosis of ARDS in that study was suboptimal, with only roughly 50% was considered mild ARDS and 79% severe ARDS. And then less than 65% of those patients were on lung protective vent settings with tidal volumes under 8 cc's per kilo, ppw, predicted body weight. So overall, that means that ARDS overall worldwide is really undertreated and under recognized. But in the States, we've advanced quite a bit. As far as pathophysiology, the main characteristic finding in ARDS is a rise in your capillary or your pulmonary capillary permeability. There's all this accumulation inside the alveoli of the protein-rich fluid, which kind of causes the injury to the capillary endothelium. This reaction is what really causes the release of the cytokines, which creates the diffuse alveolar injury. The lung has two types of alveolar epithelial cells. If there is injury to the type 1 cells, it'll cause more fluid to enter into alveoli, which would also cause a reduction in clearance of fluid. And a reduction in alveolar edema fluid clearance has been seen to be directly correlated with a higher mortality rate. If there is injury to the type 2 cells, it will cause a reduced production of surfactant, which would of course cause increase in your surface tension, a reduction in pulmonary compliance, and alveolar collapse and atelectasis. In the lungs of individuals who really suffer from ARDS, a lot of the studies say that the findings of several abnormalities that involve gene transcription from the pro-inflammatory mediators, and there's essentially a relationship between the endotoxic systemic response and the cyclooxygenase 2 gene expression induction. And characteristically, ARDS has 3 different phases: an exudative and inflammatory phase, a proliferative phase, and a fibrotic phase. However, there's no nosocomial infection, pneumonia, or vent-induced lung injury present, and they may actually complicate those phases. So the initial accumulation of fluid typically is followed within the first 3 days by a various amount of proliferation from the alveolar type 2 cells, a new matrix deposition of fibroblasts, and patients who get pulmonary fibrosis tend to present with a reduced pulmonary compliance due to its restrictive components, and that will of course kind of reduce our gas exchange and have a rise on our mortality rates. And the reason why some patients get fibrosis and some others don't is really not that well understood, but the same goes for mortality. A lot of it is due to multi-organ failure, but the studies kind of are controversial on that. But anyway, so let's move on to different types of management strategies that we've seen over the years with managing ARDS. There's been a lot of studies and a lot of advancements that have been made that actually have helped our outcome, have helped our mortality. There's anything from prone positioning to lung recruitment maneuvers to ARDSNet protocol, which many clinicians have heard of. There's the high frequency oscillator. There's lung protect strategies. There's airway pressure release ventilation, APRV. And lung protective ventilatory strategies were really made to make sure that these ARDS patients are appropriately oxygenated with appropriate amount of CO2 clearance, and without causing the least amount of injury from mechanical ventilation. A lot of what ventilator-induced lung injuries are really attributed to the excessive amount of mechanical stress that we put on these patients with big tidal volumes, gas flow, driving pressures, high rates, and so there's been these theories in some of the literature that states that the fundamental cause of vent-induced lung injury is primarily due to an excessive amount of mechanical power that we apply to these patients' lungs. So this will kind of lead people to think that providing an inappropriate vent strategy can exacerbate and worsen the initial pulmonary injury, due to, an abundant amount of mechanical stress, which is powered by, a lot of volume or pressure with which the lungs are ventilated with. And, if you inappropriately provide inappropriate levels of PEEP and may cause repetitive opening and closing of the alveoli, which, as we all know, is called atelectrauma, and which in turn would exacerbate the pro-inflammatory response. And, two popular and highly conversed methods that we're going to be going over for ventilation is APRV and the oscillator, and how we can manage these patients and really see which one is, the best management strategies for these patients. Usually when I, talk to my staff about APRV, this is the reaction I got. And it really took a couple years for me to make them feel a little bit more comfortable with APRV, and for them to actually start recommending it to the physicians to put it on, our Ards patients. And what are our typical conventional lung protective strategies that, we've seen, right? Keep plateau pressures under 30, you know, using low tidal volume ventilation, anywhere from 4 to 6 mLs per kg, using PEEP to help restore FRC, right? We've all kind of heard all these things. But is this really the best way? What if your CO2s are rising, the plateau pressure is at 30? What do we do if the patient has a high oxygen index? What if we do if the patient has a PF ratio under 200? And that's when we really start to bring in APRV. This is technically what the textbook definition of APRV is. APRV applies to prolonged, continuous positive airway pressure to maintain adequate lung volumes and recruit available lung units with varying time constants while using lower peak pressures and inspiratory flow rates than conventional, with periodic time cycle release to facilitate CO2 clearance. Right. So in other words, that's a mouthful. Let's try to break it down a little bit. APRV is really two CPAPs. You have a high pressure, you have a low pressure. We typically use it on the most critical patients. Go figure. Just like every other great mode of ventilation, it gets used as a rescue therapy when it really shouldn't. And we're going to go over that. It allows for lung protection and lung recruitment. And it permits patients to spontaneously breathe. And it's this new inverse ratio ventilation. It's really not that new, but to a lot of people and a lot of facilities, it is. And it's a continuous lung recruitment mode. How does it do it? It's a high pressure used over an extended period of time, which essentially you mean airway pressure. And this is used to inflate the areas of collapse within your lung. Applying pressure for a long period of time and short expiratory times prevent collapse or de-recruitment. And the pressure is released to a lower pressure for a certain brief period of time. That's a lot of that's going to be your time high, your TP, which is going to be your ventilatory part of this mode, and that helps for CO2 clearance. Okay, as far as your inverse ratio, we know in normal ventilation, expiration is at least twice as long as inspiration. But in this mode, inspiration can be twice as long or longer than expiration. And this allows for more gas exchange, more oxygenation across the alveolar capillary membrane. And just as a little heads up, patients can be weaned on APRV, and it's not necessary to switch into traditional weaning modes. Okay, you can actually extubate from APRV. And here's a little waveform diagram that can show you how APRV is really utilized. That top line up there, that's where your pressure high, your P high is going to be. That's essentially where the foundation of your map is going to be. The little drops, that's where your time high, that's us facilitating ventilation, so that's where the time high kind of comes into play. We're releasing CO2 just for a brief 0.4, 0.5 seconds, and we're right back up to that high pressure to prevent any collapse of the alveoli. And this has been a fairly advanced mode. Mechanical ventilation. It takes a lot of skill and training and getting a full grasp of it, because it's very different from what most clinicians are used to. But it has been gaining popularity, especially in Ards patients. And one thing I really like about this mode is that it really helps facilitate spontaneously breathing. With the potential benefits of that, you get like less sedation, short duration of mechanical ventilation days, improved cardiac performance. And it's really, if you look at this picture right here, it's essentially just CPAP that allows patients to breathe spontaneously throughout the entire cycle, um, and without any kind of significant airway pressure fluctuations. There's only that brief cycle release phase just to facilitate ventilation, and then it's right back up. It's all time triggered, pressure limited, and time cycled mode of ventilation. There's actually a study that compared low tidal volume ventilation methods to APRV, and they found that the APRV showed that a better oxygenation, better recruitment of the lung, reduced injury to the lung without suppressing the circulatory system, and they hypothesized that performing APRV earlier in ARDS patients would provide more efficient recovery of pulmonary function and would lower the amount of time that these patients spend on the vent compared to low tidal volume ventilation, such as like a ARDS or something like that. And these studies really kind of go on. There's a bunch of studies out there, and they kind of go on to explain that we ideally should be ventilating these patients and keeping the lung units open throughout the ventilatory cycle, and to prevent like lung injury. So, what kind of patients? I mean, who is this really indicated for, right? Primarily used as alternative ventilatory method technique in ARDS patients with any patient that has poor compliance, significant lung disease, reduced FRC. We want to help protect against villi. If patients who are hemodynamically compromised who may benefit from the lower PIPs and the spontaneously breathing, and that obviously makes for better patient ventilatory synchrony and comfort. And patients requiring significant sedation and neuromuscular blockade due to any kind of concerns related to spontaneously breathing. And what are some of these advantages, right? Lower airway pressure and using open lung approach, avoiding extension of lung injury, like I kind of mentioned before, restoring that FRC, limiting your adverse effects on the circulatory hemodynamic standpoint, and allowing more spontaneously breathing, right? Any kind of disadvantages, possible increase of your mean airway pressure, which may potentially reduce your cardiac output. However, spontaneously breathing usually helps compensate that. And you might have an increase in airway resistance due to the inability to really, or the fact that you might get some permissive hypercapnia, and it may be slightly difficult to eliminate CO2 due to the limited emptying of the lung in the short release periods. Then you have all this more time for lung recruitment. The constant airway pressure facilitates all that. The alveolar recruitment enhances diffusion, prevents overdistension, and enhances collateral ventilation, right? We also see, improved cardiac effects. Spontaneously breathing, like I mentioned before, has the positive effect on the venous thoracic pump mechanism by improving your VQ mismatch and improving your cardiac output, and having the blood return to the right side of the heart and improving that synchrony, right? There's less push and pull from your chest. And as you all know, decreasing sedation or eliminating the neuromuscular blockades, right? This will help improve ventilation. Patients can breathe spontaneously. We can wean them faster. There's less chance of them undergoing ICU delirium. With more sedation, we're putting them at risk for displacement of their diaphragm. Some of the advantages to having them breathe on their own, it just, it maintains a normal cyclic, decrease in the pleural pressure and augmenting the venous return, and it reduces any kind of atrophy or deconditioning of their respiratory muscles. Because during, positive pressure ventilation, atelectasis can form near diaphragm because of the inactivity of the muscles, and they start to get paralysis. And then this is how you can see how the diaphragm can get displaced. The more significantly that they're sedated, or the fact that they're paralyzed, it really displaces their diaphragm in the lung-dependent regions. So, just kind of go back from a literature standpoint. For conventional lung protective strategies, most clinicians are familiar with the Ards and that protocol, which uses those low tidal volumes, like I was mentioning before. Um, However, that particular way of ventilating can still be problematic for patients with ARDS, and the mortality rate for patients receiving that still remains fairly high, according to some of the studies. And despite the fact that the studies on APRV for ARDS patients somewhat fairly limited, but they still show drastic improvement when compared to other just regular conventional modes of ventilation. Um, they've seen improved in homogeneity, lower lung injury, and better pulmonary compliance. There was another study that was done that had approximately 6-7 patients, and they had a low tidal volume group, and then there was another subgroup that was an APRV group. All the patients characteristically were very similar, all severely ill, and they found that the APRV group had more ventilator-free days, had more successful rate of extubations. Less of their patients needed tracheostomy procedures. Obviously, like I mentioned before, less sedation was needed. They saw reduced length of stay in the ICU, and the patients in the low tidal volume group ended up needed more paralysis, prone positioning, which can be very problematic sometimes if there's not enough properly trained staff in the unit that day. And recruitment maneuvers performed compared with the APRV group. And so the mortality rates on this day of the hospital were fairly the same. Or they concluded that the early initiation of APRV in these ARDS patients really significantly helped them. It reduced their plateau pressures and reduced their ICU stay and their duration of mechanical vent days. And it really goes back to which patients really are the best fit for this, and it really goes back to those patients who really are having high mean airway pressures, and where you may benefit from having a lower PIP. Just anyone who's really at high risk for having mechanical lung injury, anyone who's having really hemodynamic compromise or lowering resistance at venous return, and patients who we just want to promote, spontaneous breathing and efforts, and want to reduce the, any kind of, sedation or paralysis. So now for settings, we have your P high, your P low, your time high, your T low, right? So your P high is essentially the inflation pressure that kind of helps open the lung, the recruitment pressure. The P low is really the low pressure the breath is released to, which is essentially just your PEEP. Your time high is essentially your respiratory rate that facilitates ventilation, and it's the time that the pressure high is applied to the lung, and it's kind of like the recruitment time. You say how long you want to stay up at that high P high or your mean airway pressure at before you want to facilitate ventilation. So typically people might start at 4 or 5 seconds on that. And your team PEEP, your time low, this is just how short of a time you want to stay at that low pressure, your low PEEP, right? It could be a PEEP of 1 or PEEP of 0, and it's it's only significantly in exhalation time. We want it to be extremely short, under half a second, to prevent any possible chance of getting de-recruitment in these patients. So as far as let's see now. Well, I guess I should say the rate of lung collapse we typically will see is typically about 45 degrees slope, and patients with ARDS are really seen at a slope of 30 degrees, which means that the ARDS patients have a quicker rate of lung collapse, as one might guess, due to their low compliance. So a lot of these articles say that they found in preliminary studies that they found that an expiratory flow to the peak expiratory flow, so if there's about negative 45 liters a minute of the end expiratory flow, and your peak expiratory flow rate is negative 60 liters a minute, your ratio is about 75%. And that's where we really want it to be. We really want our TP calculations to be anywhere between, or peak expiratory flow rates to be between anywhere between 50 and 75% to prevent any kind of de-recruitment and to help stabilize those alveoli. And for as far as initiating APRV, the recommendations really are that the inspiratory pressure, the P high, is really set at whatever your desired plateau pressure is. So typically people will get a plateau pressure in their conventional mode of ventilation, and then they'll set their P high from there. The time high is typically set to occupy about 90% of their total cycle time of each breath. The T low is really set based on change in your lung mechanics after you kind of analyze the waveforms and the slopes of the expiratory flow curve. The expiratory pressure, the P low, is really set to, as close to 0 as possible. If your vent doesn't go down to 0, then just set it to 1 centimeter of water. It's going to help minimize any kind of resistance to the convective expiratory gas flow that you might have to help maximize your ventilatory phase. And the short duration at the end of expiration kind of prevents that airway pressure from reaching the atmospheric pressure. So it kind of helps maintain almost like an auto peak. And overall, a lot of the studies really do show that, APRV does improve mortality rates in Ards patients, and it utilizes an open lung approach, which helps reduce the duration of mechanical ventilation to help improve the cardiopulmonary conditions in these individuals. So, I have yet to really see any studies that have really convinced me otherwise. It's all been very, very promoting to apply APRV in Ards patients. However, there was one study that stated it may be best to actually, with these severe Ards patients, on the early onset of their diagnosis, it may be best to have them rest and provide some, don't promote spontaneously breathing. Let them rest, give them paralysis, give them heavy sedation. And in that case, they stated that they recommended that we started APRV in the later stages of Ards, and that they actually recommended high frequency oscillator in the early stages. And we'll actually get into the oscillator right now. Here's just a little configuration showing, the circuit and all the valves, the bellow. And essentially, people get scared of this because it's such a large, noisy, dinosaur-looking ventilator. But it's really, if you think about it, there's only about 4 or 5 parameters that you can really manipulate, and it's a lot easier conceptually than mechanical ventilation. So, the oscillator was first used as an alternative ventilatory method in neonates with Ards. It does this by ventilates very small tidal volumes. It's thought to be providing 1 to 3 cc's per kg per body weight, predicted body weight, and the tidal volume is essentially under anatomic dead space with a very high respiratory rate or frequency, whatever you want to call it. And the oscillatory diaphragm or pump is really designed to provide that active inhalation and exhalation, so air is being pushed in and then it's being sucked right back out, and that's what kind of helps create that oscillatory pressure around a constant mean airway pressure. The theory and the purpose of the design is to really maintain and recruit appropriate end expiratory lung volumes, enhance your oxygenation, prevent any kind of atalic trauma, ventilatory induced lung injury in these Ards patients. And so essentially this is what our indications are, any kind of ventilatory support treatment of respiratory failure, RDS patients, air leaks, PIEs, anyone who really who needs an oxygenation requirement and is failing conventional ventilation. Some of the complications and contraindications are, you can get lung hyperinflation, you get lung hypoinflation, you can get collapse. Really don't put on patients who have a high ICP or have any kind of obstructive lung disease. Just some kind of considerations. These patients should be already be hemodynamically stable. If they're not, then you should really try to optimize their status prior to putting them on the oscillator. It increases your alveolar gas mixtures. It enhances the chance of repair by decreasing the stretching, closing and stretching, right, of your injured lung. Just some circuit things. You're going to have to make sure that it's attached to hospital compressed air to keep the piston cool. Some studies state that in Ards patients that the oscillator decreases volume trauma and barotrauma by ventilating with intrapulmonary pressures with volume changes less than the conventional ventilation. And really make sure you get a blood gas before and after, get your x-ray to make sure you're properly expanded, and try to suction the least amount of possible and suction the patient prior to putting them on, and use a TCM for trending purposes. So as far as like the parameters that we would set on the oscillator, it's really done by the RCP or physician, and that some of the things that we manipulate are the mean airway pressure, frequency hertz, amplitude and power, FiO2, inspiratory ratio, and bias flow. The mean pressure is really set to provide an adequate inflation or recruitment to facilitate that oxygenation. Right? You've heard the whole figure out what your mean airway pressure is on the conventional ventilator and start anywhere from like 2 to 5 above that. Amplitude power is really set based off your appropriate chest wiggle. With patient, and this really helps facilitate carbon dioxide clearance with ventilation. And neonates typically will like to see the chest wiggle be down to the umbilical region. With larger adult patients, we like to see the chest wiggle go all the way down to the mid-thigh, pelvic region, actually. You have your amplitude pressure that's measured proximally on the endotracheal tube, which means a lot of the pressure is attenuated by the penons of the delivery system, and it's even stated that roughly 5 to 16% of their numeric value is actually received in the trachea. However, there's some other studies that suggest possibly otherwise, which I will cover in a little bit. As far as setting frequency, some studies recommend increasing the frequency hertz as much as possible in order to minimize alveolar cyclic pressures and tidal volume. Typically, rule of thumb is babies will get a higher hertz, and adults will start at a lower hertz. And, really the theoretical benefits of the oscillator are the fact that the studies really claim that it's a lung protective strategy because of its ability to provide those small tidal volumes, prevent all that stretching, and at a very high rate to help facilitate oxygenation and ventilation. And those low tidal volumes are really thought to be beneficial and safe for ventilating these various disease Ards lungs, because they'll prevent that volume trauma and iliac trauma by reducing that shear stress. So pressures in the high frequency ventilation are higher than most accepted plateau pressures because your plateau pressure is typically only applied for a short period of time. So the pressures become attenuated before reaching the lung, and there's really minimal alveolar stretch. So it's thought to be safe in that regard by preventing kind of overdistension. And the short inhalation times really promote a homogeneous ventilatory distribution of gases. As far as ventilation, right, you're going to go up on your amplitude to help reduce your CO2. This provides more of a chest wiggle, which will facilitate more ventilation. Essentially, your volume, right? Your displaced volume. If that doesn't work and you've already tried maxing out your amplitude, you can obviously reduce your frequency, which will increase your volumes as well, and which will enhance your ventilation, get more time for CO2 clearance. And you can also try deflating the cuff as well. That's a little trick that we'll pull at the bedside. Not so much for those NICU babies. As far as oscillator managing oxygenation, we can go up on our mean airway pressure. We typically only want to see patients expand to about 9 ribs. Um, if the lung compliance improves, we really need to drop that mean airway pressure as soon as possible to prevent any kind of barotrauma or polytrauma. Um, if lung compliance improve, so my apologies. And we obviously want to try to wean FiO2, keep it under 60% to prevent any O2 toxicity. Um, so essentially, what I would say is potential risks that we really have with the oscillator, which I kind of mentioned earlier, was really the need for heavy sedation or paralysis, or just a significant, um, but possible significant reduction in your cardiac output and preload. And applying and maintaining competency can be kind of difficult in facilities, right, where there's like very minimal experience. Right, it's a high risk, low volume modality. Really difficult to transport on this. Um, Possible risks of derecruitment due to losing your mean airway pressure during, some facilities like to use the H1N1 circuits where you'd have to change out the filter on the circuit every 24 hours, and that puts these patients at a very high risk of possible derecruitment. Um, the circuits are very rigid, right, which can be unsafe when turning babies or patients, and or if it's tied down and the patient wakes up, gets up, and possibly can have unplanned extubation. And there's obviously those intrinsic factors, right, where it kind of hinders the ability of clinicians to really examine and to listen appropriately to breath sounds. Make sure there's no dislodgement, pneumos, or right main symptom intubations. And the use of the oscillator has really oops in adults with ARDS, because in the 90s to early 2000s, many places really recommended using the oscillator as a first-line treatment for early ARDS. However, a lot of more recent literature has come out that clearly states that the limitations of those prior studies. There was a meta-analysis that was conducted. It examined 6 randomized controlled trials, and they concluded that the oscillator does not decrease mortality rates, even though it does improve oxygenation. And they stated that they did not recommend routine use of the oscillator in moderate to severe ARDS. Another systemic systematic review stated, or meta-analysis also concluded that the oscillator did not improve mortality rates, and it may be actually harmful in ARDS patients when compared to conventional ventilation with low tidal volumes and high levels of PEEP. It's definitely shown to improve your VQ mismatching without causing an extensive amount of alveolar stretching over distension, a recurrent collapse of the alveoli, which is why clinicians typically will favor this oscillator. They say, "Oh, we've been working with oscillator for years, and it's never steered me wrong." However, most of those clinicians have worked in a neonatal population. Now, when it comes to an adult population, another study that was done stated that 2 large multi-center conducted trials concluded that the oscillator failed to show benefits in those ARDS patients. Much of the conducted experiments in the literature for the oscillator were primarily done in the neonatal population or small animal models, right? So, these concepts do not apply nearly the same way as adult lungs. They performed a canine experiment. Researchers found that there's regional differences in different locations in the alveolar pressure, which caused a hypo and hyperinflation in certain areas, despite the fact that the mean alveolar pressure was the same as the mean opening airway pressure. Another study that did a study on adult sheep found that the delivered tidal volumes were much higher than expected in the proximal airways, which obviously would cause overdistension and injury to the alveoli due to the extensive pressure swings. The researchers really believe that this was due to the less attenuation of pressures with the larger endotracheal tubes, right? There's more attenuation in your pressures with the smaller tube that you see in the neonatal population with adult endotracheal tubes, which are very large and there's less resistance, there's less attenuation of your pressure. From a hemodynamic standpoint, one study actually examined the right ventricular function in ARDS and patients receiving the oscillator by using a transesophageal echocardiography, and they found that over half the patients had right ventricular dysfunction and 25% of them had right ventricular failure just at baseline. When the MAP was increased to improve the PF ratio in those patients, they found a worsening of the right ventricular end diastolic pressures and left ventricular end diastolic pressures by 40%, along with a reduced cardiac index and right ventricular function, which obviously meant that these patients required a significant amount of vasopressors due to their hemodynamic compromise. Both the APRV and the oscillator are considered open lung strategies. They all provide a certain degree of lung protective strategies and reduce, ventilator-induced lung injury. However, it really depends on what exactly you're dealing with. As I mentioned before, a lot of the studies stated that the oscillator is really not highly suggested or recommended in an adult population. However, if you do need to put it on an adult, or if your facility only works with the oscillator, it's best to do it earlier on in the stages when the patient needs paralysis. You don't want to have them being all synchronous on the oscillator, fighting the vent. Give them a good amount of sedation and let their lungs and their body just rest for a few days. And then if you wanted to try APRV, it would be better in the later stages where you can kind of promote spontaneously breathing and trying to get them off the vent. Some of the bad, or I guess, and that's a disadvantage of the oscillator, right, is all the paralysis and sedation that's really needed, and the lack of spontaneously breathing efforts that a patient would get on the oscillator. However, that is essentially what I'm concluding with my findings. Here's all my resources, my references. So, yeah, thank you for listening. Hope you enjoy.